have two guest speakers with us today, and I'm really excited that they were able to join us. Craig Petit from Native American Community Health Center in Phoenix, Arizona, and Jamie McQuiston from South Dakota Urban Indian Health. And I'll be handing it over to them to talk about some of the activities and successes that they've had at their clinics. And then for the remaining time of today's session, we're going to open it up as kind of a roundtable session to give everybody an opportunity to ask questions either to our guest presenters or of one another, and share information about what may be going on at your own clinic, different challenges you may be experiencing, different successes that you've implemented, and basically just have kind of an informal and open session where we can share that information with one another. So for anyone who's not familiar, the Urban Indian Health Institute is a division of the Seattle Indian Health Board, and we were created in July of 2000. We received partial funding from the Indian Health Service to operate as one of the 12 tribal epidemiology centers, and our service population is a network of 34 urban Indian health organizations, and they're located nationwide, as many of you know. In 2007, we received funding through the CDC through cooperative agreement to work on the Weaving Project. We call it the Weaving Project, but the full name is Weaving Resources for Urban Indian Women's Wellness. And through the Weaving Project, we provide technical assistance to the 34 urban Indian health organizations, as well as the 19-state breast and cervical cancer early detection programs. I say 19 because there are 19 states that have one or more urban Indian health organizations. And so we primarily work with those 19 states as well as the 34 urban Indian health organizations, UIHO. There are several project goals of the Weaving Project. The first focuses on screening with the objective to increase the number of urban American Indian and Alaska Native women who receive screening for breast and cervical cancer. The second focuses on access, to increase access to quality, timely, and culturally appropriate diagnosis and treatment services. The third really focuses on collaborative partnerships and supporting collaborations between the urban Indian health organizations and the state breast and cervical cancer early detection programs. And then finally, to create a framework to build on successes and partnerships that can then be applied to other areas of cancer prevention, of chronic disease, other health areas as well. So as I mentioned, we work with the 34 urban Indian health organizations and the 19-state breast and cervical cancer early detection programs. So it's a really large audience that we're working with. So we provide both kind of a broad-reaching base of technical assistance as well as customized technical assistance. When we talk about broad-reaching technical assistance, we do this through things like quarterly webinars like we're doing today, where everybody can access and join in. So we also have this year our 2011 summer webinar series. So this is the first of 4 webinars that will be happening this summer. We have a website where we post all of our resources and our information, and I've included the URL here. So this is a way for everyone to be able to have access to the resources that are developed. And we've developed quite a bit of materials and resources. We have reports, we have fact sheets, state-specific fact sheets. We have recipe one-pagers, which focus on outreach and recruitment strategies. And then we do presentations whenever we're able to reach both a state audience and a UIHO audience. We also offer more customized technical assistance. So this includes on-site visits where we may do meeting facilitation, assistance with training or planning. And Sharon, as she mentioned, has worked with the Weaving Project, and she was really instrumental in doing this type of customized technical assistance for different clinics and states. In the past, we've been working with participating sites, so this was essentially 3 to 5 sites per year, and we would oftentimes visit in person. And then this year, we've also been doing outreach and recruitment award opportunities, working with sites on different outreach and recruitment events. So this is just a quick map to show you some of the states that we've been working with different levels of technical assistance. We did a lot. Urban Indian Cares. This is a group that's been going for many years, and before I was ever involved with it, so when I talk about it, I like to make the disclaimer that this preceded me, and they've just done incredible work. Urban Indian Cares, the objective is to promote education, testing, and treatment of colorectal cancer for urban American Indians and Alaska Natives through the Urban Indian Health Organizations nationwide. The original funding for Urban Indian Cares came through the Prevent Cancer Foundation and also the Spirit of Eagles. They've had membership of 22 members, 17 organizations represented, but it's largely a kind of a coalition of different Urban Indian Health Organization representatives. The work of Urban Indian Cares really began with seeking to identify attitudes among urban American Indians and Alaska Natives towards colorectal cancer screening. So this was done through focus groups and through surveys. And then this information was used to develop a number of health promotion campaign materials. The group also developed a communications portal for these materials to be accessible and really seeks to involve other urban Indian health organizations in their work. This is kind of just a quick little summary of some of the materials that Urban Indian Cares has developed. It includes fact sheets, postcards for outreach and education, and different media campaign toolkits. These materials are all available electronically on the Weaving Project website. With that note, just to let you know, for people who are here in person, a lot of these materials are available out on the table and are being passed around for anyone who's interested in seeing some paper copies of these materials. So with that brief introduction of the programs, I wanted to hand the mic over to our guest speakers to talk more about activities and successes at their clinics. And I'd first like to hand the mic over to Craig Petty from Phoenix.
Okay, and I'm even more technical limited than you.
Yeah, this is what you can deliver.
Okay, well, thank you for having me and asking us to come. I'm actually pretty intimidated because, quite honestly, all the people that are in this room, or several people in this room, know a lot more about this project than I do, really, from the perspective of having developed it and distributed it and given technical assistance about it. And quite honestly, all I've done is kind of watch my staff try to, or actually they did have done the Weaving Project. So anyway, it is a little bit intimidating. See, the Weaving I'm from Native American Community Health Center. It's one of the 34 urban clinics in Phoenix, Arizona, or 34 urban clinics, and we're the one in Phoenix, Arizona. So that one? No, next. Gotcha. Okay, I'm Craig Petty. I am the development director for our agency. Just kind of a funny note on the way up here. I flew into Portland because. Oh my God. I flew into Portland because I have lots of family in this area, and it just worked out for me to go in there and then drive up here. And as I was driving up, I remembered that about 25 years ago, I worked at an agency in Vancouver, Washington, which is a suburb of Portland, or Portland may be a suburb of Washington, Vancouver, depending on which side of the river you live on. Anyway, I drove up here to present to a committee
with the legislature, and I was terrified. You know, it was just awful for me to have to do that, and I've grown a little since then, and I didn't think this was going to be so bad, but for some reason, with all this technology today, it's pretty much it's nearly as bad. So here we go. Native Health, we call our agency Native Health. It's Native American Community Health Center. We used to have the NACHI, which was NACHCI. We got a letter from the National Association of Community Health Centers asking us to change our name. So we are now Native Health. The agency was initiated in 1978, was I think a couple of years after the first clinics were done, or first came into being. We started as a small community nursing program. We expanded to include WIC and nutrition services pretty quick, WIC nutrition services. And now we provide medical, dental, behavioral health, health promotion, and disease prevention services. We serve Maricopa County, Arizona. Maricopa County is about the size of New Hampshire. It's bigger in some countries. It's a fairly densely populated in that 2/3 of the 6 million or so people that live in Arizona live in Maricopa County. So it's a large part of our population. Urban Indians only represent about 1.8 or 2% of that county population. Now that does not count the Indians that live on reservations that reach into Maricopa County. There are 5 reservations that have fingers or are either partially or fully in Maricopa County. Just this is the last thing about Native Health. We have 2 primary health care clinics. The first one is one of the 34 urban clinics, as I mentioned. The other one is fairly new. It is an FQHC funded through 330 funding. We also have WIC clinics at 3 sites, but one of them is on the Phoenix Indian Medical Center campus, which is an IHS-funded hospital, and several clinics. And then we also are accredited, just to let you know, by the AAAAC, something that I think will be talked about later today. And we also went for the medical home status in this last round of accreditation, and quite honestly, will be accredited, we were told, along that line. So I think that it's interesting that Sacramento Group and we're in the same situation. Nobody else in Arizona is actually going for that medical home status, and so we're probably the first in Arizona. So. The Weaving Project, Breast and Cervical Cancer Prevention and Awareness. We did this in a form that I don't think is really quite what everybody else does. We had events where we had people come in and go through stations. And actually, I'm getting ahead of myself. So why don't we talk about just a little bit about where we've collaborated with the Seattle Indian Health Board in provision of the Weaving Project, and we've done 2 events so far. The Seattle agency provided us, of course, with curricula and structured plans for the activities, and they also gave us money to do the project, and so we ended up having the resources to be able to do the activities that we did. So here we are. We've done the 2 events, and we have another couple planned, I believe. The 4 things that we do, the 4 activities that we do, include the breast cancer awareness necklaces. And with the necklaces, you provide that provides an avenue for people to discuss breast cancer lumps and their significance. And as you'll see in the next picture, that it kind of gives people a tactile way to sort of know what those lumps are going to be in the way of size or feel. And then the other part, and then we also do breast and cervical cancer educational bingo. The facilitator called out information about cancer, cancer prevention, and cancer screening while calling the bingo squares. So, next. This is one of the ladies that won a prize playing bingo. And in the weaving project event, we did cookie decorating, and that emphasizes the importance of receiving regular screenings for breast and cervical cancer while participating in fun activities. Participants were given cookie cutters as prizes. The photo part, actually, we tried to photograph, actually we photographed everybody that was wanting to be photographed, which was everybody, and in groups of all kinds of groups. But the emphasis was supposed to be on photographing families or groups of women who were from the same family, and to in the process emphasize how the importance of families taking care of each other and reminding them about screening, and also that cancer does run families. I know a family that I've been familiar with for all of my life that I swear, I don't know how many people have died of breast cancer in that family. It's just incredible. And this is one of the photos, and I believe the two on the left are no, the two on the right are sisters. I don't know about the other one, but I thought they looked like sisters, so I included it. Other activities that we did during our weaving project was we gave massages. We had lunch. And I think that is really important. That wasn't part of the grant money that comes from the Seattle group. And I think it is of course important to do any function like this. And well, I'll talk about that later. Gifts and prizes. We also had Maricopa County Public Health Program personnel come in there and provide their expertise. We're partnering a lot with the public health folks with Maricopa County and doing a lot of breast and cervical cancer activities. And that is actually, we've just gotten a grant, or not a grant, but a contract from them to have them pay for breast and cervical cancer screenings for women that don't qualify for either Medicaid or have insurance or have other means of being paid or having those services paid for, but are also just can't afford them. And I don't know, that's really important right now with the way things are. I think that we've all been talking about how access to health care has really changed in the last few years. I believe that Arizona is probably the worst in the country. It is absolutely, they are cutting it every way they can, and preventative services for health for cancer are extremely limited for people that don't have means. And let's see, the thing that I also wanted to talk about was we do it in what I would call kind of a crash course format. We did all these things at one event, and the next picture, or the next couple of pictures will kind of show that. They got messages over and over several times while they were at the event. Instead of holding, a cookie baking event or holding a necklace making event, we did them all at one time at stations, and people moved around and did them. So what helped to enable successful events was that it was well organized. We had the lady that does puts the event together is very good at these kinds of things, and we have lots of willing staff and volunteers. lots of incentives. Our publicity was really good. We have newsletter and email blasts, and we put out flyers, and it seemed again that word of mouth, it's always the way that people find out about stuff, was the highest in our little survey that told us how they found out about it. And again, lunch. Susan is the lady on the right, just so you know what she looks like. She didn't want me to include this picture. Lessons learned. Plan for lots of people, more food is better. And it really is. I mean, I had to go the first time and buy a bunch of pizzas, I mean, in the middle of it. So it was, it really did, it wasn't enough. We were, I think, counting on like 30 or 40, and we both times got nearly 100. And our room is big, and it was too small. And participants had a good time, and they got the messages. I mean, we talked to people afterwards, and they told us, well, I learned this and this and this, and so they did get the messages, and I think it's repetition, They stayed for the whole thing, and they heard it several times, some of them. So anyway, it I think, did work out. Invite elders. They enjoyed the event, and I think, they're good folks to have there. Other folks enjoy talking to them, and I think that it really does, give you some credibility. We had intended for people to participate and move along. So come and have your lunch at 11:30 and do our games and do our functions and then move on, and then we'll feed another group at 12 and another at 12:30. Well, they all stayed. And, I mean, just stayed and stayed. So that's the way it was. So this is kind of what our room sort of looks like. As you can see, the front lady on the left, she's at one table at a station. Those folks were doing the necklaces. The next table back was folks doing the cookie decorating part. And then behind them, you can see the lady back in the corner there. That's one of the ladies from Maricopa County Public Health talking to somebody about just, giving them some information about cancer and cancer screening. This is another one of the elders that participated, and she was very enthusiastic. She likes me, so I like her. This is some of our staff, and I'm going to just tell you a little bit about them. I guess, am I running out? Am I going too long?
I think we have about 10 minutes of this session left, but...
Okay. Just to tell you just quickly who our staff are, these are more than these people did work with us, but the person on your left is our alternative resources person, so she enrolls people in Medicaid. The person next to her is our HIV person, HIV prevention program. The person next to her, the guy in the middle, is one of our dental assistants. Then we have an administrative person, and then the person on the far right works with families for young mothers who are high-risk pregnancies and those kinds of things, to help them with case management for the first 2 years of the child's life. And this is just a picture of the necklace activity. And this is a picture of the bingo. And this is one of our board members. And next to her is one of the ladies that helped us learn this. Notice our board member is wearing one of the necklaces. And these are folks from another agency that happen to be in our same building. And that's it. Thank you.
Thank you, Craig. We'll leave questions for the end. I want to make sure that Jamie is able to get through.
Good afternoon. My name is Jamie Christian. Like I said earlier, I'm a RN at Urban Indian Health. Just a little bit of background is the way I really got interested in cancer screenings and cancer in general is, well, nursing first. I took a class in high school with medical occupations, was taught by a nurse, so she really obviously promoted a nursing career. I followed chemo administration nurse in the Pure Hospital, which they don't do a whole lot of chemo, but she's awesome. She's still there, and I've loved it ever since. So I'm a patient navigator at our clinic, and it was when the opportunity came around, when the grant got started, I nabbed it because I am very passionate about cancer and people getting their screening. So I work at Urban Indian Health, like I said. It's in Pierre, South Dakota, which is located right in the center. We have two other facilities, one in Aberdeen and one in Sioux Falls. At our clinic, we have 3 providers. They're all 3 nurse practitioners, which are women, and then me and another nurse. So we are spread pretty thin, but we get the job done, I guess. At our clinic, we focus on 3 cancer screenings, the breast, cervical, and colorectal screenings. We do that through 2 programs. The first one for the mammograms in the past is the All-Me Count program. It was a program that started in South Dakota in 1997, although Urban Indian Health didn't start get involved with the program until 2002. It is a program funded by the CDC. I think somebody mentioned this grant here before. It's the National Breast and Cervical Cancer Early Detection Program. Each state kind of has their own name for that program. South Dakota, we had a contest. It was a nurse that actually chose the name for the program, All-Me Count. So you can see the amount for the grant, the fiscal year, that's how much they run on. You can see the numbers there of how many people we have screened. 332 women have been enrolled in the All-Me Count starting in 2002, and that is just enrolled. Women can re-enroll every year. You get PAP every other year, mammograms every year, and then it's kind of a branch off of the All-Me Count program. It's the Wise Women program. Women have the opportunity to, it's not even a separate enrollment. We just offer the lipid screen at the same time. Everybody wants it. It's never an issue of not doing that. So they were doing the PAP every year until the guidelines changed in 2009. Through this program, you can see our numbers. There are 471 PAP smears have been performed and 213 mammograms have been performed. All of this at no cost to the patient. Oops, sorry. Read my speaker. I'm probably 2 slides ahead of you now. Okay. All at no cost to the patient. Okay. And we'll go to the next one. For the eligibility, we have the ladies all sign the form, and if they rescreen, we check their eligibility again. They must meet the income guidelines, and it's the same as the federal poverty guidelines. Can't be enrolled in Medicaid. Obviously, those services would already be covered through that, so that makes sense. And if you have not had a hysterectomy or had a hysterectomy due to cervical cancer or dysplasia, you aren't eligible for the program. But and you must meet the age requirements. But a little blip here, though, is if you have had a hysterectomy due to cervical cancer or cervical dysplasia, they will cover one pelvic exam. So they still, they cover everyone. Oh, and if the patient, like I said, you have to be 30 years of age or older. But if you are 27, you come in and you have a bunch of symptoms, lumps found during the clinical breast exam. I call up Roberta. She's on my speed dial at the Department of Health. She's like the lead of the All-Me Count program, and she will get them in. She'll do the exception. And I already talked about the Wise Women services. We do check the BMI, lipids, and the blood glucose. That's kind of an offshoot of the program, but very important one. I don't think I said this before. For South Dakota, we have less than 1 million people in our entire state. So program in South Dakota so that we can start the mammograms at age 40 instead of age 50, and the PAPs at age 30. And that's unlike other states where they start at 50. So we definitely get people screened. And that's about it for the All in One Count program. So moving on to the other program that we have available at our clinic in South Dakota is the Get Screened South Dakota program. It was started in 2010. South Dakota Urban Indian Health was in PEER, one of the 6 pilot programs, and it's currently in its 2nd year. Grant money comes from CDC, you can see the amount there. Since the program began, 133 FOBPs have been distributed and 5 colonoscopies have been performed. Every single one of those colonoscopies, polyps were found. So it's very beneficial to the patient and a pretty good chance that that could have turned out not so great for them had they not received that colonoscopy. And I can tell you that none of those patients would have been able to afford that colonoscopy had it not been for the Get Screened South Dakota program. The eligibility must be 50 years of age or older. The thing with this program, which was encountered at the beginning of the All in One Count program when it was started, is the patient can display no signs or symptoms of cancer in the past 3 months. So if someone does come in, say, I'm having rectal bleeding, I'm having this constipation, they have a huge family history of cancer and, they're not showing signs of it, they're not eligible for this program. They're trying to work on that. It really stings, it breaks my heart. I'm trying to figure out something for them, some type of program, but as of now, they cannot enroll in this program. And the same thing was with the All in One Count program when it first started. The program would pay for the screening services. If a lump was found, too bad you have to pay for the treatment on your own. That doesn't really make sense. If they couldn't afford the screening, they can't afford the treatment. But since South Dakota has such a high disparity rate to begin with, there was actually an act that was approved through Congress, and she tried to, Roberta from Department of Health tried to explain it to me. I'm a nurse, not a legislator, but the funds are connected with this act that was passed in South Dakota, the Medicaid Treatment Act, and that's the way that these women, the treatment is covered for these women. It's not actually through the All in One Count program, it's actually through the Medicaid program, if that makes sense. I hope that's making sense. Okay. So that's how the treatment for the positive FOBP is funded also. The other thing too, which I think is awesome for the eligibility, if you have Medicare but you can't afford your deductible, what they'll do is bill your Medicaid first and then bill the Get Screened South Dakota program if they don't cover everything. So even if you do have coverage, sometimes those deductibles are huge and you can't afford that either. So like I said, they do such an awesome job of getting people screened. It's awesome for South Dakota. You can see the reimbursable services here. They pay for the FOBP, the colonoscopy, the sigmoidoscopy, and the exam, the prep, pathology fees, everything. The patient is not going to come away with a bill in any way, shape, or form. Things they do not pay for are the genetic testing. Like I said, any treatment related to the diagnosis. It is a screening program, not a diagnostic program. So like I said, if they come in with symptoms, you can't do anything for them as of now. Hopefully we get some funds in the future to pay for that. And then of course, if they have irritable bowel syndrome or something of the sort, they're out of the program also. One thing I forgot to mention too, if they do come in with diarrhea, constipation, some of those general symptoms that could be colon cancer but are more likely due to something else, I'll look at their meds and I'll have the provider write a note saying this patient is on whatever, and I'll send it to Roberta at Department of Health and she'll okay the consult. They don't get disqualified from the program just because they have diarrhea. We all know that can be a million different things. Successes with the program. This is with the Get Screened South Dakota program and the All in One Count program. South Dakota, in PEER, we have all the state offices in a real close vicinity. Roberta, who I keep mentioning, she's on my speed dial. I talk to her 40 times a day probably. She is in charge of the Get Screened South Dakota program, the All-Women Count program. She was there when they were both started. So I call her. She knows we all are in such a good vicinity. We can talk to each other. We can go to webinars together. We all go to the same stuff. It's awesome. Also, all the staff down there are nurses or been involved with these types of programs for years. If I say FOBT or if I say whatever, they know what I'm talking about, so we don't spend half of our telephone conversation reviewing redundant things. The other success is the Patient Navigator program. I got involved with it. We got a grant through CDC and asked me to be the patient navigator for our clinic. And I think that started in January. And I just basically make sure every single patient that comes into our clinic is screened. If we aren't asking them about their cancer screening history, if we aren't talking to them about it, who is? Their family is depending on us to do it. We can't leave that responsibility to someone else. I'm such a stickler about cancer screening for our patients. I've only been there since October, but patients know me when I come in because I badger them. Most of them in the winter say, I'm going to wait for spring. Well, I put it on my calendar, ask so-and-so about cancer screening in the spring because they'll try to put it off as long as possible. The numbers screened, like I said, we screen everything. If they come in for a cold, we ask them when their last mammogram was. It doesn't matter what the visit should be for, we should always be asking. And the state's working together to ensure coverage. If a patient, say, living on the border in South Dakota is positive, or they come back with a lump or something, then they can go into, like, their border of South Dakota and North Dakota. They can go up to North Dakota and get their treatments in North Dakota and South Dakota. Like I said, that Medicaid Treatment Act, that'll cover, the North Dakota Medicaid Treatment Act will cover that. So the only thing that doesn't work with is the Get Screened South Dakota program. If they have a test positive in South Dakota, they have to get their treatment in South Dakota, or they have to get their colonoscopy in South Dakota. With the Patient Navigator program, again, sorry, this is another thing I'm pretty passionate about. Harold Freeman, who started the Patient Navigator program in New York, he actually started it in Harlem. He came to South Dakota, to Sioux Falls, to the American Cancer Society funded for him to come here. And if anybody has the opportunity to listen to him speak, it's amazing for what he's done and how far he's brought that program and what he's doing with cancer screening. Like I said, I'm in charge of the cancer screening program. There's people in the larger hospitals where we refer people out to Sanford or Avera that take care of the actual process of doing the chemo. They are the patient navigators within those facilities. As we know, the healthcare system, if I got cancer, I don't even know if I'd be able to navigate through it. There's so many ins and outs of it. It's awesome to have those types of people there that know what to do, can tell you where to go, what to do. And I believe you were, sorry, people on the phone don't know what I'm pointing at, but, and then there's the patient navigators for after survivor patient navigators, basically, that can make sure people are navigating that process also, because we know that it can be a very, very lonely process after you're a survivor. So we are all working closely together. The challenges, like I said, I've only been at my facility since October, but I've talked to a lot of people who were there when when the All-Women County Get Screened South Dakota program started, and they said initially with the All-Women Count program, providers were hesitant to get involved with the All-Women Count program, didn't know what it was about, didn't know it would take a lot of time for training their staff, so not a lot of people got on board right away. A patient at their facility might say, hey, I want to get involved in this, I'm eligible for this All-Women Count program, can you give me these services? And they say no. Doesn't make a lot of sense. But with a little education, most of them got on board. That's with South Dakota Urban Indian Health as well. We got in like year 5 of the program. And then I already talked about initially there were only funds for the screening and not for the treatment. But like I said, with this All-Women Count program, that did change once that Medicaid Treatment Act was passed. Other challenge, this one is going to make my hair turn gray when I'm only 24, and that's a pretty big deal to me. But getting patients to return their completed FOBTs is such a challenge. It's such a waste of resources to send these things out the door, and people don't ever do them. And it's a waste of resources. I'll do anything to get them to turn back in. I call them. It's a struggle. One thing I've tried to talk about is, or try to get my clinic involved with, is incentives. I don't know if we can try to do gift cards, or, because that helps with our HIV screenings. We do $5 Walmart gift cards, and you won't believe how that will increase your screening rate. So that's the positive consequence I'm thinking about. The negative consequence I'm thinking about is maybe having the person pay out of pocket for that screening if they don't turn it back in. We put stamps on it. There's no reason for them not to complete it. I do all the education with them ahead of time. There's no reason for them not to do it. And so we're thinking about implementing a negative consequence as well. We'll see. Questions? Sorry if I rambled.
Thank you. So we're getting right up to the end of our time. Maybe if we could just open it up for one question, and then if we don't get to everyone's question, I would invite you to go ahead and submit them to me. Let me pull up a new screen with my contact information. So is there anyone in the room or on the webinar who has a question for Jamie or Craig or myself? For anyone who didn't hear that, the question was for Craig about how did the clinic get 100 women to come to the event?
We put out flyers, and quite honestly, our building has about 6 services that are all targeted to Native Americans. We have vocational services on one floor. We have housing services. We have another agency that provides behavioral health besides that. And so a lot of that was just people that are in the building. Our newsletter is really well read. We get a lot of people open and really read it. So it was in the newsletter, and we went and talked to the seniors, and the seniors told us, or the seniors told all their friends, and so we didn't really do it for a long time, but we got all those people this quickly.
I'm going to have, I don't want to take up time we have a session coming in after us, so I apologize that we don't have more time for question and answer, but if you do have questions and you're here in person, I encourage you to connect afterwards. For those of you on the webinar, my email address is on the screen. Please feel free to send me any questions, and I'll be happy to share them with our guest speakers. And I just want to say thank you to everyone for joining us today, and we will be in touch again shortly. For those on the webinar, we will also be sending an evaluation survey, and we would love your feedback to see how this format works and how we can improve it in the future. Okay, thank you, everyone.